Hello, my name is Qambar Hasan, and I'm a second-year medical student at the Nova Southeastern University Dr. Kiran C. Patel College of Osteopathic Medicine. Today, I will be presenting a clinical vignette highlighting acute infrarenal abdominal aortic and bilateral common iliac artery occlusions in an elderly female. I would like to thank Dr. Chandler Griffin and Dr. Alexander Dorfler for their collaboration and mentorship with regards to this presentation. Acute aortic occlusions are rare events in terms of clinical presentation and their representation in today's literature, as an understanding relies significantly upon individual case studies, case series, and retrospective analyses. In fact, one of the few available statistics estimating the condition's incidence at 3.8 per 1 million person years comes from cases obtained from a vascular database maintained for the Swedish population. Primary causes typically implicated in the development of an AAO involve embolism and thrombosis. Clots of the proximal aorta can lead to the occlusion of the superior mesenteric, renal, or spinal arteries, yielding ischemic complication of the gastrointestinal system, kidneys, and spinal cord. The signs and symptoms of acute lower extremity ischemia involving pain, diminished pulses, and paresis are how acute aortic occlusions typically present. Treatment of acute aortic occlusions often entails surgical revascularization to the pelvis and lower extremities with techniques including axial bifemoral bypass, aortoiliac thromboembolectomy, and aortoiliac stenting. A retrospective study examining perioperative mortality after AAO revascularization found the axial bifemoral bypass procedure to be the safest choice for a vast majority of AAO patients. However, for patients considered high risk and with minimally diseased aortoiliac segments, aortoiliac thromboembolectomy is typically performed. Another retrospective study has shown the condition to possess a 30-day postoperative mortality rate at 27.7% and a lower limb amputation rate at 15.4%. With regards to our specific case, a 76-year-old female with a past medical history of obesity and atrial fibrillation controlled on warfarin presented to the emergency department complaining of bilateral lower extremity pain and weakness. The patient noted that her symptoms began abruptly while making breakfast when she lost the ability to move her lower extremities. On presentation to the ER, her vitals included a temperature of 36.5 degrees Celsius, sinus tachycardia with a heart rate of 130 beats per minute, a respiratory rate of 18 breaths per minute, pulse oximetry of 98% on room air, and marked hypertension with a blood pressure of 180 over 83 millimeters of mercury. Pertinent physical exam findings included her general appearance, notable for severe distress, secondary to pain. Her skin was significant for a cool mottled appearance of the lower extremities with dusky appearing toes. The cardiovascular system was notable for irregular tachycardia without palpable femoral, popliteal, or pedal pulses and delayed capillary refill of the bilateral feet. The neurological exam was significant for flaccid lower extremities with diminished sensation. Coagulation studies revealed a PT of 20.2 seconds, an INR of 1.7, a PTT of 31.1 seconds, and a serum lactate of 3.4 millimoles per liter. A CT angiogram of the aorta demonstrated occlusion of the infrarenal abdominal aorta along with occlusions of the right and left common iliac arteries, with notable reconstitution of the right and left external iliac arteries secondary to collaterals, as shown in Figure 1. The celiac artery was also found to be occluded at its origin. Additionally, 50% stenosis was noted in the SMA due to plaque formation, and mild stenosis was observed in the inferior mesenteric artery secondary to calcified plaque. Plaque formation was also observed at the origins of both the right and left renal arteries without significant stenosis. Results of the CT angiogram warranted embolectomies of the abdominal aorta, bilateral iliac arteries, and bilateral femoral arteries. Her vascular surgery service had estimated that 4 hours elapsed from the time of symptom onset until the presentation of the patient in the OR. Following embolectomies, the operative note demonstrated strong femoral and pedal pulses. On postoperative day 1, her mild acute renal injury and lactate acidosis resolved. Ultimately, the patient did not require amputation, and on postoperative day 6, she was subsequently discharged home. Of note, the elderly female patient in this case was noted to be obese, a condition which has been associated with hypercoagulability and can potentially lead to deviations of aortic blood flow. It is imperative that future research addresses the potential link between obesity and AAO, since obesity is a known risk factor for more common causes of infrarenal abdominal vascular catastrophe, such as aortic dissection and aneurysm. In terms of additional avenues for future research, a meta-analysis and systematic review may be the only way to provide definitive diagnostic treatment recommendations for this life-threatening condition. Thank you all for your time and organization of this competition.